officer in HKL and continue to become a clinical pathologist also in HKL since 1988. But she became a pathologist since 1997 until now. Sorry, she's a anatomic pathologist and neuropathologist since May 2007 until now. Okay, and previously she also involved or conducted in many courses related with the neuro pathology as well as neuromuscular pathology, and and she also involved in giving teaching to the undergraduate student and also postgraduate or clinical teaching for the postgraduate student. So she also involved in many publications, especially in neuromuscular disorder. Okay, so I just want to give a bit introduction of the neuromuscular pathology. Actually, is rare. If not, I think only in government hospital we only have in at
Patayura.
yeah, sorry, I turned left. Okay, so we continue. So today we are really lucky to have this session. Actually, I think I don't know. I think we never have this session before. To know about what is the neuromuscular pathology service. So, and as you all know that this neuromuscular pathology service only had in HKL for the government setting, and we received the referral in the whole Malaysia, and usually most of the cases are directly sent to us from the clinician. So I think it's good to have this session. At least you all have a brief knowledge what is a muscle neuromuscular pathology, and what is the indication to send the specimen, how to send the specimen, everything. So with all my honor, and without further ado, I would like to invite Dr. Sue to deliver her presentation. So Dr. Sue, the floor is yours now.
Okay. Thank you very much, Dr. Haizura, for kind introduction. Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to everyone. Boleh dengar ya? Can you hear? Boleh ya? Boleh ya? Okay. Okay. Now it's my turn to present at IAPMD, and just before my retirement, which is end of this year. Actually, it's next year, early next year, 2nd January, but my last day will be on 30th December this year. Okay, I'm happy to deliver this lecture because at least I passed my knowledge about neuromuscular pathology, and I hope that it will give some enlightenment for everybody about neuromuscular pathology. Yeah, because a neuromuscular pathology is a very highly specialized field, and very highly specialized, and you need a good clinical correlation. It's actually same as renal pathology and other but in neuromuscular pathology, you have to have a good clinical correlation, good laboratory correlation, imaging, and also the neurophysiological findings. Okay, so okay. So I will present some essential diagnostic advice for a non-neuropathologist. At least you know what we do in our lab. Yeah, I won't teach you how to diagnose neuromuscular disease because it will take years, you know, for me to master in neuromuscular pathology. Take years for me to master after I came back from training in Japan, but it take years for me to know more about neuromuscular pathology. Okay, so this is a little bit of advice for everybody. At least if the clinician asks you in your center, you can give some ideas to them. Okay. Okay. So my topic, my discussion today I will cover this topic: introduction, gender indication for muscle biopsy, specimen transportation, specimen preservation, muscle biopsy stains, and interpreting a muscle biopsy. This is, I just give a quick review, view about how to interpret muscle biopsy. Okay. Okay, muscle or nerve diseases are a subgroup from neuromuscular affection in which the primary pathological process involves the muscle and nerve. Okay, patient with neuromuscular disease present with symptoms like weakness, episodic muscle cramping, numbness, myalgia, or sometimes patient may come with rhabdomyolysis. Okay. Muscle or nerve biopsy are important diagnostic procedures in neuromuscular practice. Yeah, and muscle biopsy is needed when the result of the assessment indicate that muscle weakness might be caused by a muscle or nerve disease. Now, sometimes muscle weakness not due to muscle disease or nerve disease, but sometimes because some changes in the brain that cause muscle weakness. So if the assessment indicate that it is caused by nerve or muscle, so muscle biopsy is needed. Yeah, muscle pathology findings are helpful from differentiating myopathy of various causes. Yeah, so you will know after this what are the causes or what are the myopathies. Yeah, okay. And assessment of patients with muscle weakness and interpreting muscle or nerve biopsies requires careful correlation of pathological alteration with detailed clinical information, detailed neurological examination, electrophysiological studies such as nerve conduction study or EMG, electromyographic study, laboratory investigations and imaging studies. Okay, what are the indication for muscle biopsy? Okay, first we think, okay, the patient come with muscle weakness. Is it inflammatory? And some inflammatory is chronic, and it can mimic limb girdle muscular dystrophy. So it's indicated for you to do a muscle biopsy because immune-mediated myositis, it is treatable disease. Yeah. Okay. Some disease does not have either antibody or genetic association. Yeah. Like immune-mediated myositis, there is antibody, what we call myositis-specific antibody. Yeah. But actually the changes in muscle biopsy is helpful, although there is myositis specific antibody, but it is overlap. Yeah. Contoh myositis specific antibody, anti-SRP, anti-HNG-MCR, anti-JO, anti-RO, anti-MDA5, and anti-ME. So but they are overlap. Yeah, overlap in certain diseases. So you need muscle biopsy to confirm your finding. Or there is some disease that's no genetic alteration or genetic association. Some diseases require special treatment regime, such as immune-mediated
video ni muka kita nampak kan?
Which can be it is a treatable disease. Yeah, so you need a muscle biopsy to confirm the diagnosis. And some require pathological diagnosis. Okay, presence of some evidence of muscle. Okay, patient come and there is evidence of muscle disease such as weakness, as mentioned earlier, weakness, muscle symptoms like discomfort, cramps, fatigue with activity. Yeah, patient become easily fatigued when they do a strenuous activity, and sometimes patient comes with elevated CK. Some people presented with elevated CK, but there's no symptoms. What we call hypercemia. yeah, hyperschemia. So some clinician will do muscle biopsy to know the cause of the elevated CK. Yeah, myopathic on is it there is changes in in EMG, either myopathic or neuropathic or abnormal nerve conduction study, and presence of neuropathy for which nerve biopsy is indicated. Okay. There is also systemic disorder which is associated with muscle changes. Maybe the there is silent manifestation in systemic disorder. There is systemic disorder, but they have silent manifestation in muscle. Yeah, contohnya immune or inflammatory disorder. Actually, the cause of myositis or muscle weakness is due to vasculitis or sarcoidosis. Yeah, it's not directly because of the muscle, but because of the disease in the vessels, vasculitis or sarcoidosis, that cause muscle weakness, or amyloid, yeah, or neoplasm, or usually paraneoplastic syndrome. One of the presentation is dermatomyositis, yeah, either lymphoma or adenocarcinoma, or mitochondrial disorder. Yeah, okay. Okay, there are cases which are not indicated for muscle biopsy, which some disorders are better diagnosed by electrodiagnostic methods, such as myasthenia gravis or myotonias. And some diseases like DMD and BMD, Duchenne muscular dystrophy or Becker's muscular dystrophy, there is established genetic study. So there is no need for the clinician to send muscle biopsy if they suspect DMD or BMD, because it can be diagnosed by genetic study. Yeah, so nowadays I rarely got requests from the clinician for this diagnosis. Yeah, because they can send genetic study to confirm the diagnosis. Okay. Okay, how you select which muscle to do biopsy? Yeah, okay. In chronic disease, muscle with moderate but not severe weakness is the best site to do muscle biopsy. Okay, some clinician they thought that the worst weakness is the best site in chronic disease, but it's not, because when I received the muscle from that the specimen from that muscle, usually it is already end stage muscle disease. What you see is only fibrosis and fatty infiltration. There's no muscle fibers to look for you to make diagnosis. Okay, but in acute disease, you can take muscles from severe or moderate weakness because it's acute. So the changes in the muscle is still not yet not progressed yet. Okay, but the best specific muscles is deltoid, biceps or quadriceps. Why we choose these three muscles? Because it is well studied. Yeah, well studied. You know how many percent is type 1 fibers, how many percent type 2 fibers, how many percent type 2A, 2B, and 2C fibers. So this is well studied. So we are very comfortable with muscle biopsy from deltoid, biceps or quadriceps. And if patient present with proximal muscle weakness involving upper limb, so you take from deltoid or biceps. If it is involved lower limb, so you can take from the quadriceps muscle. But we not from other side. I got request to do from ocular muscle because there is ophthalmoplegia. But actually, ophthalmoplegia is a systemic manifestation like mitochondrial myopathy. Yeah, so it's a systemic. Actually, you don't need to take from the ocular muscle, but you can take from biceps or quadriceps. Yeah? Okay. Okay. Sometimes you need MRI to select pathological muscle site in difficult cases, and also you need to avoid muscle that were site of EMG injections or trauma. Okay. Okay. In HKL. Okay, we set up muscle lab. We set up muscle lab since 2000 when I came back from Liverpool in 2000. So we set up muscle lab, but at that time it's very minimal tests, minimal stains that we can do. When I come back from it's more established when I came back from Japan in 2007, whereby we my MLT, Puan Nur Hafizah, which already retired, she set up the lab. Yeah, she was with me in Japan to learn how to set up the lab and also to do the technical part of processing muscle biopsy. Okay, so in HKL you need arrangement. Requires prior arrangement with pathologist or MLT at least 1 day before the procedure. Okay, why we need at least 1 day arrangement before the procedure? Because I have to make sure that my technician is around when the muscle arrive in my lab. Yeah, because it is a fresh tissue and we have to immediately snap freeze the tissue. Yeah, so if the tissue, if the specimen lying in a common counter or any, and only the next day that we realize that is muscle biopsy, maybe they put in fridge, but actually it's already the enzymes already gone. Yeah, so we have to immediately snap freeze the muscle tissue. So my MLT has to be standby. Yeah, we have to know how many muscle biopsy is arranged for today, and we have to stand by. How many MLT needs to stand by? Yeah, so that's why we need prior arrangement. Yeah, okay. Information required on request form: full clinical history, the presentation, age at presentation, whether the patient active in sport, what is the performance at school. Is it able to climb staircase? Is it there is numbness, or patient need to use walking aid, or need to need to hold at the handrail when climbing the staircase, and is there weakness? Yeah, muscle weakness. Is it distal or proximal muscle weakness? Yeah, if distal, there is some diseases that associated with distal myopathy. And most of the presentation are proximal muscle weakness. Okay, and if I need a good family history. Okay, is there muscle weakness in the family? And if there is muscle weakness, I need a family tree. How many involved? Is it involve the male or only the female? Yeah, so because it is some hereditary disease. Yeah, you have to know the involvement, is it male or female. Okay, and examination, want to know the power of the each muscles, the tone, sensation. Is there Gower sign? Is it floppy? If it is from infant, is it floppy? Is it frog-like posture? And go on. There are so many presentation. Okay, and I need to know the creatinine kinase level. It is mandatory. Especially in cases of inflammatory myopathy, it is mandatory for you to have creatinine kinase level. And also, if some cases, if patient can afford to pay for the myositis specific antibodies, because myositis specific antibody is done in private lab. Yeah, so I need to know what are the myositis specific antibodies which is positive. Yeah, okay. Okay, LDH also is also important if suspecting mitochondrial disease, and I need to know EMG findings and nerve conduction study findings, imaging, because in inflammatory myopathy you can see changes in the muscle on on imaging. Okay, and clinician contact details and referring hospital fax number, because it's much easier if I can fax the result or I can email the result, and also I need the clinician contact number for me to discuss with them. Yeah, because sometimes, most of the time, I get very minimal history, proximal myopathy for investigation. That's all. Yeah, it's very difficult for me to make diagnosis. Yeah, because the changes is overlapping. Yeah, it can be inflammatory, can be dystrophy, dystrophic muscle. It's all similar. So you need to know the full clinical history. So the clinician contact is very important. Okay. Okay. Now we go to specimen transportation. Okay. You can do open biopsy or needle biopsy, and most of the time they do open biopsy. Remove at least one good cylinder of muscle measuring 10 by 5 by 5 centimeter in diameter. Okay, 10 diameter, 10 diameter and thickness 5. And it's 3-dimensional. Muscle specimen to be wrapped in a slightly wet gauze, then wrap with aluminum foil and send fresh in an airtight, dry and clean container. Yeah, and please do not touch the muscle directly. Actually, this one is for clinician lah, for the surgeon who did the muscle biopsy. Okay, but you can advise to the clinician if they call your lab. Okay, specimen to be transported with ice or gel ice, not dry ice. Please, not dry ice. Yeah, dry ice can be used if the muscle already being snap freeze at your center. Yeah, and do not tie the muscle to stretch it. Do not put the tissue on dry gauze. Actually, the gauze should be wet with saline, with normal saline. The gauze, after you put in normal saline, you squeeze the gauze until there's no more dripping from the gauze. Then you can put the muscle on it. Yeah. Do not put in saline or formalin. Yeah. Do not immerse your muscle tissue in saline or formalin. Yeah. Okay. Because it will degrade your enzyme. Yeah, enzyme is very important in muscle biopsy. Okay, need to send muscle biopsy specimen within 3 to 6 hours upon removal. However, for optimal result, specimen need to be as fresh as possible. Yeah, if can send within 1 hour and the weather is not too hot, transport in container at room temperature. If to reach lab within 3 to 6 hours or in hot weather, transport in container with ice. Okay. Sometimes our lab is in Neuro, in Institute Neuro, and to transport the snap freeze tissue. This what happened previously. Okay, transport the snap freezing was done in Institute Neurology, but for sectioning is done in the main lab. So the transport from the Institute Neurology to the lab, to the main lab, the tissue already thawed. So there will be ice crystal artifact. But now everything done in Institute Neurology. Yeah. So that's how critical is this muscle biopsy. You cannot. Must make sure there's no thawing process going on, because it will cause ice crystal artifact and it's difficult for you to make an interpretation. Okay. Okay, specimen transportation, do not let the muscle directly contact with the ice, and transport frozen muscle, which already being snap freeze, in dry ice. Avoid freeze and thaw the muscle. Yeah. Muscle biopsy specimen should be sent to the neurology laboratory at level 1, Institute of Neurology HKL or histopathology unit, main building. Yeah. Okay. Okay, how you preserve the tissue? Okay. Okay, this is the specimen that we receive. Okay. It's fresh tissue. Okay. And then we measure it. This is quite big tissue, but 30 mm. Yeah. So we cut accordingly. Okay. Can you measure this? And then trimming. You trim the tissue, remove if there is fascia or fat. You remove the fascia and fat, and you just take only muscle. Then after that, you have to orientate the muscle under dissection microscope, because you want to see the fibers. Yeah? How the fibers, we want to take cross section. So you want to make sure that it's embed cross section, not longitudinal section. Okay. Okay. Then once you prepare your muscle, now you have to prepare the base. Yeah. So we need a cork. and also tragacath powder. And so you have to mix with water, okay? And this is the base preparation. This is the cork, gabus, we made it ourselves lah. And then this is the gum tragacath. Okay, susah. Okay, base to hold muscle tissue. This is the cork and this is the gum. Okay, and this is how you embed muscle tissue into the base. Yeah, so you put your tissue into the gum. Okay, this is how it looks like before it snap freeze. Yeah, this is the optimal size. But not this one. This is too big. Yeah, this is too big, so you need to cut more. Yeah, okay. Okay, and now preparing isopentane in liquid nitrogen tank. Yeah, so this is the liquid nitrogen tank, and the isopentane is in the beaker. Yeah, so actually, okay, this is wrong. This is just use glove biasa je. You should wear a glove, the green color glove that can withstand minus, because this isopentane in liquid nitrogen, the temperature is at least minus 60 degrees. Yeah, so you cannot wear this type of glove. Yeah, okay. Okay, see, this is the liquid isopentane in a beaker. Yeah, okay, in a beaker, and this is the muscle which already been embedded within the gum on the cord. Yeah, okay. And then we will put in the liquid nitrogen tank. Yeah, so and then dia keluarkan asap lah. Yeah, and you have to make stroke 40 to 80 times within 1 minute. Yeah, so it must be very the MLT should learn how to make the stroke. Yeah, and this is how it looks when it is already being snap freeze. Okay, and after that we put in container and label it, and we will store it in minus 80 degrees freezer, deep freezer, and you can freeze it lifetime. Yeah, you just make sure that electricity is working, and it is the temperature is always minus 80 degrees. Yeah, okay. What is okay? You go to physiology of the muscle. Okay, this is muscle bundle. Okay, this is bone and the tendon, and this is the attachment to the muscle. Okay, and this is one fascicle. This is one fascicle, and within the fascicle there is muscle fibers. Okay, so this is one muscle fibers. Okay. This is one fascicle, okay? And in between the muscle fibers, what we call endomysium. And the one that wrap in between each fascicle, we call perimysium, okay? So this is another view. It is one fascicle, and this is the muscle fibers, okay? Okay, the muscle fibers, there are two types, okay? Type 1 and type 2, yeah? And this type 2 can be divided into type 2A, 2B, and 2C, okay? And type 1 usually high oxidative enzyme activity, utilize Krebs cycle, adapted to sustain activity, and correspond to red fibers in animals, okay? And type 2, highly phosphorylase, depend on intrinsic glycogen, you utilize glycolytic pathway and design for rapid and sustained activity, and correspond to white fibers in animals. Okay, so these are the different fiber type. Fiber type 1 usually is red and slow twitch fibers, but type 2A is also red but fast oxidative fibers. Okay, and type 2B is white for fast glycolytic fibers. And usually this fiber type 1 we commonly seen at the postural muscle, at the neck and spine, and also in the leg muscles. And this leg muscle also, they have type 1 and type 2A fibers. Okay, and type 2B fibers usually, usually in fibers at the arm muscle, yeah? And usually short, fast bursting power, but rapidly fatigue. Yeah, example in heavyweight training, powerlifting, or 100-meter sprints. Yeah? Like in 2A, usually in 400-meter sprints. Yeah? And in activities involving speed and strength and power. Yeah, usually they would use type 2 fibers, and type 1 usually for walking or low density cycling for 30 minutes. Okay. Okay, what are the muscle types? Sustain. Okay. There are a few muscle types sustain. If you want to see morphology, you do hematoxylin and eosin, or Gomery trichrome, or VVG. Okay, and if fiber type enzyme, you will do ATPase stain, different pH. Yeah, and oxidative enzyme, you do NADHDR or succinate dehydrogenase or cytochrome oxidase. Okay, and glycolytic enzyme, phosphorylase or phosphofructokinase. Yeah, and hydrolytic enzyme, you want to see in you can see in under acid phosphatase or non-specific esterase, or acetylcholinesterase or alkaline phosphatase. Yeah? And so if you want to see storage disease, yeah, pastain, yeah, like glycogen, or Asian blue, mucopolysaccharide, or Sudan black for the lipid storage, or oil red O, yeah, for lipid storage, aminoadenine alpha GP for reducing bodies. Yeah, so not all these stain I do in my lab. Only some stains that we have in our lab. Yeah, because some are rare disease, so it's not cost effective to have them. Okay, others are congorate, yeah, to see for amyloid, and these are very rare stain, yeah, and it's not. I didn't do all this stain. Okay, okay. Routine stain in HKL, HNE, we do two levels. Gomery trichrome, NADHDR, yeah, to look for the enzyme, okay, acid phosphatase, alkaline phosphatase, and ATPase. Previously, you saw the ATPase is 9.4, yeah, 4.6 and 4.3. But in my lab, I do at pH alkaline 10.8, 10.7, and 10.6, and acidic pH 4.6, 4.5, 4.4, and 400. But usually I do 4.6, 5, and 4.3. Yeah. Why? It depends. Actually, it depends on the lab. If you read most of the muscle tissue, muscle neuromuscular disease book, like Dubowitz, or that, they mention 9.4. Yeah. But in my lab, we are more comfortable with this pH. Yeah, it depends on the lab. It depends on the environment. The pH is so critical. No, if just by 0.1 degrees, 0.1 changes also, it will change the morphology. I mean the staining. You change the stain already. So from the we try to do 9.4, but it's too dark, so I cannot interpret. So we do many pH when we choose which is the best in our lab. Yeah, but some, like in Japan, they do. They didn't, because there are 4 seasons. Yeah, 4 seasons, and different season you have to do different pH. Yeah, because it depends on the environment. So so in Japan, because they got a lot of money, so they will do from 11.3 up to 4.3. Yeah. So they don't need to think, okay, during summer these are the pH, during winter these are the pH. So they do all 11.3 up to 4.3. 4.3, yes. But in our lab, this is the best pH level, give the optimum result for to differentiate muscle, different types of muscle. Okay. Okay. And histochemistry is to demonstrate the specific fiber types, like ATPase, ATPase 10, actually to demonstrate specific fiber types and their selective involvement in disease. Yeah, some disease that is fiber type 1 predominance. Yeah, like congenital myopathy, they are mainly type 1 predominance. So you can see from the ATPase 10, you can see which one is more predominant. Is it type 1 or type 2 predominant? And there are absence of the enzyme in some diseases, or there is some excess or deficit in particular storage disease, or there will be structural changes. Yeah? After this, we discuss what are the changes. You can see in, okay, this is HNE stain paraffin section, okay, but this is formalin, okay, okay. To interpret muscle disease, it is best to view when it is cut cross section. It's not longitudinal. Yeah, longitudinal is difficult for you to see each fiber type. Yeah, each fiber type. Like this one, you can see each fiber type. Okay. Okay, here, yeah. This is one fiber, okay. And if from the ATPase thing, you can know which is type 1, which is type 2 fibers, okay. Okay, this is one muscle fiber, and is capillary here, and in between the two fibers is the endomysium, and the one that's surrounding the fascicles is called perimysium. And the nucleus of the muscle fiber is always at the periphery. When it is at the center, it is pathological. Yeah. And if it is small, usually it's only one. If it is small, it's also pathological. Okay. And this is another stain that we routinely done, modified Gomery trichome stain. Yeah. This is type 1 fiber, this is type 1 fiber, this is type 2 fibers. Okay. Okay. And another stain, this is not routinely done, but where you can, I will order it when I suspect lipid storage disease. Okay, usually you hardly see lipid in the fibers. Okay, fast stain. Okay, this is not routinely done. Okay, this is type 1, this is type 2 fibers. Okay, I only do fast stain when I suspect glycogen storage disease such as Pompe disease. Okay, okay. Okay, this is the enzyme histochemistry, acid phosphatase. Yeah, acid phosphatase, you want to see when there is necrotic fibers, there will be increase in acid phosphatase. And also in alkaline phosphatase, when there is inflammatory myopathy, you will see increase in alkaline phosphatase at the perimysium. And also this ATPase, this pH, and cytochrome oxidase, usually you want to see in mitochondrial disease, succinate dehydrogenase, also for mitochondrial disease. And sometimes we do dual stain, yeah? Cytochrome oxidase and succinate dehydrogenase, yeah? And NADH, okay? And this is the example of acid and alkaline phosphatase. Actually, this picture taken from Duchenne muscular dystrophy. Usually, if normal, you shouldn't have this. Yeah? Normally, it should be clean like this. Yeah. This one is in necrotic fibers. That's why it increased. Yeah. In normal, in non-disease fibers, usually it will be non-staining lah. Okay, and this is acid phosphatase, alkaline phosphatase, and alkaline phosphatase. You can easily visualize the necrotic and regenerating fibers, and also there will be increase in alkaline phosphatase at the endomysium and also perimysium. Okay, and usually see this in the inflammatory myopathy. Okay, and this is NADH TR stain on frozen section. Okay, this is what we want to see is intermyofibrillary network. Yeah, this is type 1, this is type 2 fibers. Okay, the intermyofibrillary network, because some disease there will be the intermyofibrillary network will be disorganized. Yeah, okay. Okay, this is succinate dehydrogenase. Usually, if it is mitochondrial disease, the succinate dehydrogenase will be increased. The color at the membrane, the membrane, will be enhanced. Yeah, I'll show you later. Okay, and this is cytochrome oxidase. This is in normal muscle, and in mitochondrial disease, some fibers will be darkly stained. Okay. And this is ATPase at 9.4 on frozen tissue. You can see it is checkable appearance. This is type 1 fiber, this is type 2A, and this is type 2 fiber, 2B fibers. Okay. And this is ATPase 4.5 acidic. This is type 1, this is type 2A and 2B fibers. Okay. And other stain is immunohistochemistry to demonstrate extracellular proteins such as collagen or laminins, or sarcolemmal proteins, dystrophin or sarcoglycans, or cytoplasmic proteins such as actin or desmin, or nuclear proteins, amyrin or lamin AC. Okay. Okay. And in HKL, we have dystrophin 1 to 3, sarcoglycan, alpha, beta, gamma, delta, and gamma. We have merosin, we have alpha dystroglycan, and we have dysferlin, collagen 6, and MHC class 1. Previously, we have this, but now we difficult to get a supplier for MHC class 1. Okay, and this is example of normal staining for dystrophin 1, and this is the dystrophin at different level, I mean different thickness, 3 mm, 5 mm, and 8 mm, and this is a normal stain, normal stain, and this is a beta sarcoglycan. The stain, the positive stain is at the membranous, and this is normal. If it is abnormal, will be no staining. Okay, and this is dysferlin, also at the membranous, and this is the HNE of a patient with dysferlinopathy. And this is how it looks like, normal control, and if patient, there will be lost membranous staining. Okay, what are the pathological abnormalities of in muscle? Okay, I just give a brief one. Just to highlight some what are some neuromuscular disease. Okay, usually when we see muscle biopsy, what should be in your mind? Okay, whether is it normal, is it abnormal, is it neurogenic, is it myopathic, or is it dystrophic? And you have to see at this changes. Okay, changes in fiber size. Is it small fibers or large hypertrophic fibers, atrophic fibers, or abnormalities in fiber type distribution? Is it fiber type grouping? Which fiber type that is grouping? Is it small group atrophy or large group atrophy? Okay, changes in sarcolemmal nuclei, and then you have to see for degeneration and regeneration, and also necrotic fiber, and you have to see for cellular reaction. The inflammation, is it lymphocytes in the perimysium or in the anomysium, or is it around the necrotic fibers or around the normal fibers? Because in some, especially immune-mediated necrotizing myositis, we have to look inflammation around a normal fibers, not around the necrotic fibers, because in necrotic fibers is a normal reaction. That when you have your muscle tissue or muscle fibers necrosis, it will attract all the lymphocyte towards it. So it's a normal reaction. But if the lymphocyte is around a normal fibers, so it is pathological. Okay, so you have to see, and then another one is cytoarchitectural changes. Okay, and changes. First one, changes in fiber size. Is it atrophic fibers? Is it hypertrophic fibers? Is it selective type 1 fiber atrophy or selective type 2 fiber atrophy? There is increased variability. You can see very small fibers or just pycnotic nuclei, and some different sizes of the muscle fibers. Okay, in type 1 fiber atrophy, usually you see in this, it is not exclusively in this disease, but you can usually commonly seen in these diseases. Dystrophy myotonica, rheumatoid arthritis, myotubular atrophy, nemaline myopathy, congenital fiber type disproportion. Okay, and type 2 fiber atrophy, and these are the commonly seen in this type of disease. Okay. And abnormality in fiber type distribution, small group, as I mentioned earlier, small group atrophy, large group atrophy, or atrophy at the perivascular area, there is fiber type grouping, fiber type predominance, or fiber type deficiency. So you have to have that in mind for you to diagnose neuromuscular disease. Okay. Abnormalities of fiber type distribution can either small group atrophy or large group atrophy or perivesicular atrophy. Okay, in small group atrophy, it is characteristic of denervation. Okay, large group atrophy is exclusively in denervation. Okay. Because small group atrophy can be seen in dystrophic muscle, yeah, like Duchenne or limb-girdle muscular dystrophy. Small group, they cluttered together. So if the history and also the pathological findings shows suggestive of limb-girdle or muscular dystrophy, so you have to with these findings, you can suggest that it is a limb-girdle muscular dystrophy, beside the other immunostain and also genetic study. Okay, and perivesicular atrophy is seen specifically in dermatomyositis, but if the features, the clinical history, the myositis specific antibody are suggestive of dermatomyositis, but there's no perivesicular atrophy, you can suggest that it is a dermatomyositis, because you have to remember that at what time, at what stage the clinician take the muscle biopsy. Maybe at that time there's no more perivesicular atrophy, it's already regenerate, the cells are the fibers already regenerate, but then there's no more perivesicular atrophy. But the clinical history like Gottron nodules, eczema, tightness, and the malar rash, or that we suggest dermatomyositis. So you can suggest to the clinician that possibility of dermatomyositis need to be considered. Yeah, like I remember last 2 weeks I went CPC with Prof Wong in UMMC. One swimming Malaysian swimmer. She come with Gottron nodules on the knuckle, yeah, and eczema, or that, but muscle changes, there's no perivesicular atrophy, and the myositis specific antibody consistent with dermatomyositis, such as MDA5, anti-MDA5, or anti-Me, or anti-Jo, so that suggests of dermatomyositis. So we name the Prof report as suggestive of dermatomyositis, although there is no perivesicular atrophy. Yeah, so that's the clinical history and laboratory investigation is very, very important. Okay, fiber type grouping is seen in chronic denervation and reinnervation. Yeah, because when there is denervation, when one of the fibers being cut off, so the other fibers, the other nerve, one nerve that supply for, contohnya the nerve supply type 1 fibers and are being cut off. Okay, so the nerve supplying type 2A or 2B fibers will be proliferate. So it becomes fiber type grouping. Yeah, so that suggests chronic denervation and reinnervation, and usually the diagnosis that we made is neurogenic change. Okay, abnormalities of fiber type distribution, fiber type predominance, presence of type 1 fibers more than 55%, of type 2 fibers more than 80%, because the ratio type 1 to type 2 is 1:2. Yeah. In normal muscle. Okay, predominance of type 1 fibers commonly seen in Charcot-Marie Tooth disease and also in congenital myopathy. Yeah, and predominance of type 2 fibers commonly seen in motor neuron disease. But this is not exclusively. It can be seen in many other types of neuromuscular disease. Okay, fiber type deficiency when it's less than 10% of fibers constitute of the group, or deficiency of type 2 fibers usually commonly seen in limb-girdle muscular dystrophy. Like dysparlinopathy, usually type 1 fibers will be more predominant. Okay, what are the cytoarchitecture? Yeah, you will see target fibers, central cause, moth-eaten, tubular aggregates, ring fibers, cytoplasmic bodies, rock bodies, regulatory fibers. And just to mind you, these changes are not classical to any neuromuscular disease. It can be seen in many different many neuromuscular disease. Yeah. Okay. Okay. This is contoh target fibers. Okay. You see the need. That's why NADH TR stain, enzyme stain is important, because we want to see that there will be intermyofibril network will be disrupted. Yeah. Okay. And this is central core disease. Okay. How differentiate between target fibers and central core? Okay. Central core, there will be involvement of the whole, all the muscle fibers, but target fibers in certain muscle fibers. Okay. And you have to know the history. Yeah. Okay. And this is moth-eaten fibers. This is moth-eaten fibers. And this is tubular aggregates fibers at the tip of the muscle fiber. And this is ring fibers. Okay. And this is cytoplasmic bodies. Okay. There is cytoplasmic body myopathy, but if 80% of the muscle fibers contain these cytoplasmic bodies, but if there is only some muscle fibers, it is non-specific. It can be seen in this dystrophic muscle. It can be seen in myositis muscle. So it is non-specific. Okay. But if it is more than 80% involving of the muscle fibers, we call as cytoplasmic body myopathy. Okay. This is ragged red fiber. This ragged fiber because the accumulation of the abnormal accumulation of the mitochondria at the subsacral region. Okay. And this is nemaline rods. Okay. Nemaline rods. Okay. And so when you see all these changes, so you have to make up your mind. Is it a myopathy? Is it a neurogenic? Or is it a dystrophic? And just based on the pathological changes, it's very difficult. So you have to know the clinical, laboratory, and electrophysiological study and imaging study. Yeah, but it will help you in making the diagnosis. Okay. Okay. Contoh. This I'm giving you some other examples. Myopathic, which is but the findings are non-specific. Yeah. Perivascular and endomysial inflammation, single fiber necrosis or regeneration, increased variability in fiber size, increased central nucleation, selective type 2 fiber atrophy, type 1 predominance, fiber splitting, wall fibers, moth-eaten fibers. This you can see in myopathic. Okay. Some are specific, macam perivascular and endomysial inflammation. If you see a perivascular lymphocyte infiltrate, it will suggest immune-mediated necrotizing myositis. Okay. Perivascular atrophy commonly seen in dermatomyositis or rod body myopathy. Central cause may suggest central core disease, yeah, or ragged red fibers. Although it is non-specific, it can be seen in inflammatory myopathy, but or dysprolynopathy. But if there are many fibers in the muscle biopsy contain ragged red fibers, suggest mitochondrial disease. Okay, or rim vacuoles commonly seen in inclusion body myositis, and you have to correlate with the clinical. Patient is at what the presentation is at what age, because in inclusion body myositis, usually the patient will present more than 50 years old. Okay, if less than that, it is not inclusion body myositis. Okay, inflammatory myopathy can be acute, can be chronic. Patient usually present with proximal or distal muscle weakness, with muscle pain, skin rash, malar rash, eczema, Gottron nodules, or patient may present with dysphagia in dermatomyositis, and you have to know what is the age of the presentation. Is it older age or younger age? Okay, younger age can be juvenile dermatomyositis. And this the classification for inflammatory myositis is what we call, the big group is idiopathic inflammatory myositis, and under this group, either it is dermatomyositis, inclusion body myositis, or immune-mediated necrotizing myositis, either anti-SRP or anti-HMGR myositis, or anti-synthetase syndrome. Now you didn't see polymyositis, kan? No, there's no more polymyositis now. Yeah, There's no more. There's if no. We because now we can specifically, because you got antibody to do the stain, so now it's more specific. We have antibody against anti-SRP. We have antibodies for HHMGR. We have antibody for synthetic syndrome, and other antibodies like MDA1 and ME for dermatomyositis. So now we can specifically diagnose immune-mediated necrotizing myositis based on the antibody. Yeah, so there's no more previously polymyositis tu semuanya actually is immune-mediated necrotizing myositis. Yeah, okay. Or either sarcoidosis or granulomatous myositis. Yeah, when there is granuloma, or can be infection, viral, bacterial, or parasitic infestation. Okay. So this is the contoh-contoh dia. Okay, idiopathic myositis. This is endometrial inflammation, lymphocytic infiltrate the endometrium. Okay, and this is the contoh-contoh lah. Okay, this is the necrotic fiber. Yeah, necrotic fiber. This is regenerating fiber. This is regenerating fiber. You see the fiber, the nucleus are large. Yeah, nucleus are large, and the staining are more dense, and there are multiple nucleus. Yeah. This is the perivascular inflammation. Yeah, usually you see this in the perimysium. Yeah, so when there is perivascular inflammation and there is myophagocytosis, you may suggest it is an inflammatory necrotizing, immune-mediated necrotizing myositis. Yeah, and this is also a regenerating fiber. This is necrotic fiber, and this is what we call perivesicular atrophy. Atrophy. This is one vesicle. Yeah, this is another vesicle, and the atrophy at the at the edge. Yeah, at the edge, what we call perivesicular atrophy. Okay, and this is sarcoidosis. You can see granuloma, and inclusion body, you can see vacuoles. Yeah? You see vacuoles. Yeah? Sometimes the changes are very subtle. Your eye must be sharp, yeah, to look for the vacuoles. And this is this is the vacuole. Yeah, and when you stay with Gomery, you saw this. Okay, rim, what we call rim vacuoles, and it contains some degenerated material. Okay, so this is inclusion body myositis. Okay, congenital myositis usually present at birth or early childhood, floppy infant, hypotonia, muscle weakness, but often, but not always, delayed milestone. Yeah, sport activity, whether the child can do sport activity, or at what age become less, and performance at school, whether it is intelligent or intermediate or poor. Okay, usually nemaline myopathy, they are intelligent. Yeah. So their performance at school are good. Yeah, and inheritance can be recessive, dominant, or X-linked. Okay. So when you examine the patient, floppy, myohypotonia, frog-like, and then usually you have to look for high arch palate. Yeah, it is a 10, not doom. Usually kita ni doom. Yeah, if it is 10 like apa tu, tekan 10 tu. Yeah, so it's sharp at the top, the most top one. Yeah? So high arch palate, myopathic facies, muscle weakness, or arthrogryposis. Okay, so these are the knee. Okay, this is floppy infant or and then there is head lag. Yeah, still cannot control. This is normal. Now you can control the head, and this is floppy baby. Yeah, and this is frog-like posture. Yeah, frog-like posture. And this is what high arch palate. Yeah, it's the 10 shape, not doom shape. And this is myopathic facies. And then these are different congenital myopathy. Ini sikit aja ni. There are many more. Okay, commonly seen. Yeah, central core disease, mati mini core, nemaline, yeah, or rock body myopathy, myotubular myopathy, or central nuclear, congenital fiber type disproportion, and others. Yeah. Okay. And this is nemaline. You can see this is on HNE state. You can see something here, yeah, at the edge. of the fiber. And when you do modified gamma ray trichrome, you can see the rod-like structure at the tip of the muscle fibers. Okay, this is central core disease. Yeah, central core. So there will be destruction of the intermyofibrillary network. Okay. Okay, metabolic myopathy, either glycogenosis, mitochondria, lipid storage, periodic paresis, malignant hyperpyrexia, or myoglobinuria. And this is mitochondrial myopathy. You can see on this is on HNE. There will be enhanced staining at the periphery of the muscle fibers. Okay, and when you do, this is NADH or SDH stain, there will be enhanced staining at the periphery of the muscle fiber. Okay, and this is the modified gamma ray trichrome. Okay, this is modified gamma ray trichrome. You can see the regular red fiber and regular red fiber in NADH stain, and this is cytochrome oxidase. This is the other dense staining. Okay, and this is glycogen storage disease. Remember that I show you the normal fibers, normal staining, and this is the patient with glycogen storage disease. Okay. This is lipid storage. This is normal, and this is the accumulation. Okay. Endocrine, this is very rare. Muscular dystrophy, delayed milestone, can have difficulty with gait, running, jumping. And Gauerstein can have cardiomyopathy, lumbar lordosis, scoliosis, swinging scapula, waddling gait, calf hypertrophy, and you must know the age of presentation. And I commonly seen Duchenne, DMD or BMD, or limb girdle muscular dystrophy, either recessive or dominant, LGMD1A or LGMD2A sampai 2Z. Yeah, but commonly seen until 2G. Yeah. But there are few cases I diagnosed as titin myopathy, FSHD, OPMD, or congenital muscular dystrophy. And these are the fiber type 1 predominance, and central nuclei is increased. And this is lobulated fibers, usually commonly seen in LGMD2A, calpinopathy, and fiber types, fiber split fibers, okay, commonly seen in dystrophic muscle. And dystrophinopathies, these are the Duchenne muscular dystrophy. Yeah, this is Becker's. The staining is slightly less, and this is Duchenne. Yeah, they are completely unstained. Yeah, and neurogenic. Okay, these are the changes. Angulated fibers, target fibers, group atrophy. Yeah. Fiber grouping, fiber predominance, and these are the changes. The other diseases, motor neuron disease, amyotrophic lateral sclerosis, or SMA. It can be type 1, type 2, or type 3. Yeah, and these are the small angulated fibers in neurogenic. Yeah, neurogenic, small angulated fibers, and this is angulated fibers, and they are cluttered together. They are grouped together, and these are grouping, small group atrophy, yeah, small group atrophy, and okay, and these are the small group atrophy with target fibers, okay, and this is what we call large group atrophy. Usually, is commonly seen in SMA, what we call bimodal distribution, small group and large group, okay, large fibers, okay, and this is the target fibers, okay, and okay, the key point. Muscle and nerve biopsy may provide valuable information for clinician evaluating patient with neuromuscular condition. Can either open or needle biopsy, and interpretation, as I mentioned earlier, must be very careful, and correlation with the pathological, clinical, and laboratory investigation. And histological, we have to do enzyme, electron. In most centers they do electron microscopy, but not in our center. Immunohistochemical techniques and only be used when it's needed. Yeah, okay. Electron microscopy and immunohistochemical stain only done on selected cases based on clinical data and histochemical findings. And also now genetic testing can provide a specific neuromuscular diagnosis. So, so there's no need to do muscle or nerve biopsy. Yeah? And vast majority of patients with peripheral neuropathy, nerve biopsy is not necessary. As specific diagnosis can be made based on clinical assessment and electrophysiological and laboratory studies, and also genetic testing. So with that, this is my center in Kodaira, Tokyo, Japan. This is the main hospital. Then this is the neuroscience center where I was trained here. And these are my supervisor, Professor Donaka. Dr. Nishino is not here. Okay, this is during our farewell. Okay, this is Hafizah. And this is, actually they are not technicians, they are scientists. All these are scientists. Scientists doing the technical work. Okay. Okay, thank you very much. I hope it will give some ideas to you all about what is neuromuscular, how we process muscle biopsy, and changes that you have to look in muscle biopsy. Okay, thank you.
Yeah, thank you to Dr. Su. Thank you for the very informative and wonderful talk. So now we come to the question and answer session. So far, nothing.
Okay, okay. At the moment, the clinician in the in other hospital all direct to me. They call me and they will send, and they do the arrangement for sending the muscle biopsy. But now all the reports I will send to the lab. Like macam apa ni in HSA, HSI, they specifically mention please send to pathology, anatomic pathology, apa ni, because they were, and then after that, I don't know, maybe they transcribe into their LIS, and the clinician can view. But some I email to the clinician. So I don't know what are the apa ni practice in different hospital. But if there is no the clinician didn't give any email address, I will email to the lab.
Yeah, actually, you all also can ask about the procedure, because the sample sometimes is not via the pathology lab directly from the clinician. So you can ask anything to us because the service is at HKL only. And then maybe Dr. Su can explain a bit how to transport the specimen if the specimen comes from Sabah, Sarawak, because they are come by flight.
Usually, okay, Sabah Sarawak, they called me one or sometimes 1 week or 2 weeks earlier. So I asked them, they have to prepare the muscle biopsy. I mean, the clinician and the surgeon has to work together, and plus the transport. Yeah. And who going to transport the knee? Usually they ask the MO to bring the tissue to HKL, or sometimes when the neurologist coming for meeting, so they do a few biopsy, 2 or 3 biopsy, and they bring together. And usually I told them it's within maximum is 6 hours. Because after 6 hours, the enzyme will be degraded. So the preparation, the ni apa semua tu, transportation, as what I explained earlier, and they have to make sure that from the time they take out the specimen to the airport and to the flying to HKL must be within 6 hours. So they have to, actually I remember where there is meeting in KK, where at that time the Dr. Norin request to all the muscle biopsy to go through lab. I was not there, but Dr. Niash, at the time, Dr. Niashima said that if you go to the lab, you have to you have to arrange for the transport. You have to transport the need to transport the need. So you have to arrange the ambulance or that. So because of that arrangement, so they call off. So nanti let the clinician do all this arrangement. So I don't know. It's up to you all whether if you can arrange the transport and send to us, it's okay. Just make sure that here we receive within 6 hours.
Okay.
I have a question. Can you hear me?
Yeah.
Hello.
Yes.
I have a question. Can you hear me?
Yes.
Yeah, Dr. Noreen here.
Dr. Noreen.
Suryati. Oh, excellent presentation. Very informative on the overview of muscle services here. I have two questions.
Yes.
First question about the muscle pathology service. As for now, how many neuromuscular pathologists that we have in Ministry of Health and University, and what is the way forward on the number of the pathologists? As you know, muscle pathology is so specialized in terms of the expertise as well as the laboratory service, right? Yes. Question number two, in a situation of hypercytokemia, asymptomatic, but the CK is high, LDH is high, the muscle power and tone are all normal, everything is asymptomatic, and myositis marker, only one marker is positive, like anti-PL7, that is threonine tRNA transferase. Do we need a muscle biopsy in these cases, or enough to make diagnosis of inflammatory myopathy?
Okay.
Thank you.
Okay, for the first question, at the moment, myself and Dr. Haizura is reading the muscle biopsy. And now we have one in training. She's in Japan now, Dr. Nur Aizan from Hospital Selayang. So she will be joining, she's now doing neuropath in Akita University in Akita, Japan. And she will be joining Dr. Nonaka and Nishino in Neurology Center, Neuroscience Center in Kodaira, Japan. Same with my supervisor in December until February. So she will come back in March. Okay, so I hope they will take over my muscle services. So there's Fadli in Kuantan, but he don't have the muscle lab. Yeah. So I don't know whether it is cost effective to set up another one, because the most muscle biopsy that I receive are from Johor. From Johor to all over, HSI, HSA, Kluang, Batu Pahat, Muar, yeah, from Johor. And Melaka also, because there is neurologist in Melaka, there is quite a number of muscle biopsy, and also from Sabah and Sarawak. Yeah, others like Kedah, Kedah also, Penang, but not as many as Johor. Yeah. And others are in Klang Valley. In Klang, I got many from Klang because there is neurologists in Klang, and also from Selayang because neurologists and also rheumatologists. Yeah, I do get cases from rheumatologists and also from me. So at the moment in government setting, it's only me, and I'm going to retire soon, and it will be taken over by Dr. Haizura and Dr. Nur Aizan. Okay, in university setting, Prof. Wong is already retired. But he do come to UMMC to teach student and also to make service in UMMC. And I think Dr. Man in university. So and other university there's no need, and they send to HKL. They send to HKL either from UITM or from USM, but or UIE, but they have to pay. They have to pay. Okay, for the second one, I still need the muscle biopsy because hypercalcemia sometimes not diagnostic pun but you have to look for the changes, and also PL7 or PL12. It's not PL7. It is usually associated with respiratory symptoms. So and it is some other. I mean, you can suggest, but it's not confirmatory. So you still need a muscle biopsy.
So where will the biopsy be? Because EMG normal, which side is the best?
Usually, if me, usually I request from bicep or deltoid. It depends on where is, or there's no presentation. So usually it's from bicep or deltoid.
Okay, thank you so much.
Okay, welcome.
There is one question in the chat box. How about the TAT for age biopsy?
Okay, for biopsy, we put as 2 months. Yeah, 2 months. Because the problem is okay, to process one biopsy, it will take a few days. Okay. Cutting is very difficult to cut because fresh tissue, you have to make sure that when the tissue arrives, we snap freeze first. Okay, we snap freeze first, immediately snap freeze because we want to prevent ice crystal artifact. Yeah, so once it's arrived, we have to snap freeze. We cannot just put in the fridge and lying a few hours or the next day. No, you have to do it immediately. That's why I need appointment, yeah, so that my staff will be standby. Sometimes they have to stand by until night, especially those from Sabah, Sarawak, or from other states, So we have, she has to stand by. So because she has to do snap freezing immediately, okay. So after that, they put in the minus 80 degrees, and these people, they also doing other what special stain, what immunostain. So when actually in HKL we have one dedicated one every to do. I have 2 now. Okay, have 2 now. So they rotate. And then in one evening, they will go to the neuro lab to do all the cutting and staining, and also the cutting take another few days. Then the staining, especially the pH, must be you must make sure there is a correct pH or that. So sometimes they have to repeat, they have to so the process is about take one week or to do the stain. But sometimes because they are tight with other job like immunostain or that, so they delay in the muscle. But our TAT is 2 months in our buku perkhidmatan tu, it's 2 months.
I'd like to make some comment. Is it okay?
Okay.
Yes, I'd like to make some comment on the specimen transportation. There are a few reasons why we need it to go through the lab. I still can remember. Number one is we need to record what are the specimen that is referred to the other laboratory. So if they didn't go through lab, we would not have the data. And number two, we also need to budget all these things. For example, if you send for referral, wherever it is, we need to budget. So we need to have the data. So we always want it to go through the lab, because otherwise we could not get the data. So those are some of the reasons why it goes to the lab. And furthermore, the third one, maybe when they want to inquire about the report, maybe missing specimen or delayed, the laboratory will not have record if it doesn't go through the lab. I remember those things, but I'm not sure people have some reason why they didn't go through the lab, maybe some other reason.
Yeah. I have no problem with that, either from the lab or direct from clinician, but just make sure that it's reached me within 6 hours. So how the arrangement with the individual lab, it depends in the hospital.
Thank you so much.
Okay, welcome.
There's no more question in the chat box, but I want to ask, I think, 2 questions. If not ask question, actually I just want Dr. Su to inform who that they can contact to make the appointment.
Macam mana, Zura?
The from the periphery, they need to contact MLT or us to make appointment to send the muscle biopsy.
I see. Usually the clinician will contact me, and then after usually I will discuss is it indicated or not. Sometimes they want to send myasthenia gravis. Myasthenia gravis actually is not indicated for muscle biopsy. So after discussion, then they will contact the lab. They contact the lab for appointment. Yeah.
Okay. And then maybe Dr. Su can give the estimated number of total cases of muscle biopsies per year, so they can know what is the
okay. So far it is increasing now. Now it's up to 120 cases per year. About that lah, 120 cases per year.
Okay.
Dr. Zara?
Yes.
Okay. Thank you very much, Dr. Suryati, for enlightening lectures. Dr. Haniza from HSAJB. Okay, since Dr. Suryati said many samples from Johor, may I know, is there any problem so far in the specimen transportation? Because so far all the clinicians will directly refer and discuss with you for the specimen transportation and reporting?
So far, no problem.
So far they can manage to
Yes,
arrive
they
within
they can manage to arrive within the time, and also I easily can contact the clinician. We have a good rapport. I have a good rapport with them, so can easily contact them. Okay.
Okay. Thank you very much, Dr. Su.
Dr. Suryati, Zara here. Just to confirm, I have one question. Just to confirm. So basically, if let's say us as a histopath in our lab, I mean from another hospital, if our clinician wants to send a muscle biopsy, so we should give the directive to talk directly to and make appointment with you, Dr. Su. Betul tak?
Boleh. Or sometimes they contact the MLT.
Okay.
Actually, if you want to do snap freeze in your lab also boleh, and send for interpretation to us. I mean, send the muscle biopsy for us to interpret. Boleh. You snap freeze. But what happened in Japan? They snap freeze at the periphery hospital, and they send to the center, neuroscience center in Tokyo, after snap freezing. And then they send guna dry ice.
Dr. Su, so snap freeze, all the MLTs know
MLT, you have to send MLT to our center for training. Tapi you kena set up lah. You kena ada liquid nitrogen, you kena ada isopentane. So liquid nitrogen tu you can share with hematology yang buat itulah molekular yang buat yang freeze dia punya kan. So you can previously we share with hematology, but now because of the increasing in the sample, so we have our own liquid nitrogen.
Okay.
You think which is best for you all?
Okay,
balik kot.
I think there is no more question. So we already come to the end of the presentation.
Haruza, can I just make some comment announcement?
Sure.
Yeah. Well, I would like to make announcement for all the participants here that the IAPMD conference, the next year, June 2023, we already start to open the registration. So grab for the early registration. You can, it is already open. All right. Thank you so much.
Yeah, thank you, Dr. Nurin. So we would like to say thanks again to Dr. Su for the excellent talk today and to the audience for your attention. And I hope this presentation will be beneficial for everybody. So I pass again to Mrs. Chairperson, Dr. Zara.
Thank you, Dr. Haizura. Thank you, everybody.